Hello and welcome to our discussion on intersegmental tracts. So, under the intersegmental tracts, we have here your reflex arc and the types of reflexes that we have. So, components of the reflex arc include a receptor that is able to detect certain stimuli. You have your afferent neuron, which gets up to your spinal cord. You have your interneuron, which connects your sensory or afferent neuron to your efferent neuron, which we have next. So efferent or motor neuron, same thing. And lastly, you have your effector organ. And this is how a reflex pathway or a reflex arc is made. So we have three major types of reflexes. Number one, we have your monosynaptic reflex. So monosynaptic would mean that this type of reflex has one afferent neuron and one efferent neuron. So examples of this pathway are your deep tendon reflexes. So in deep tendon reflexes, for example, this is your quadriceps muscle. This is your patella. This is your gastrocs muscle. And this is your foot. And this is your bone. Okay, very basic drawing. But anyway, so we've already established, right, that when there is a deep tendon reflex, when you tap your patellar tendon, a sensory neuron, afferent neuron, goes up, and one efferent neuron goes down. And this is what allows you to have the action of knee extension, right? So this is monosynaptic reflex. Now, what about your bisynaptic reflex in where you have two afferent and two efferent neurons? So to take a DTR, a stimulus is set, an afferent neuron goes up, and from the tendon, right? So from the tendon, my afferent neuron going up, and from the interneuron passing it on, an efferent neuron goes down and tells your quadriceps muscle to contract, and therefore you get knee extension. On the other hand, there's another pathway for your reciprocal inhibition reflex, wherein it now senses that there is contraction with your muscle. It sends it up to the brain or to the spinal cord to get integrated or interpreted, sends it via an interneuron. And from the interneuron, it sends the signal to the opposite muscle, in this case, let's say your hamstrings, to tell your hamstrings to inhibit or to stop its contraction. So this is your reciprocal inhibition. While one pathway tells one muscle to contract, the other pathway tells the other muscle, the antagonist muscle, to be inhibited or to relax. And this allows a more efficient movement of the agonist muscle. Again, when you say reciprocal inhibition, what is being inhibited is the antagonist muscle to allow for greater degree of movement or contraction of the agonist or the prime mover muscle. And this pathway is an example of a bisynaptic reflex in where there are two afferent neurons and two efferent neurons. So I hope this is clear with your bisynaptic reflex as well as that of your reciprocal inhibition. So this isn't limited to your patellar reflex, of course. It can happen with voluntary muscle contraction, which explains why, for example, when we want to flex our elbow, our biceps muscle is active while our triceps is inactive. Okay, and lastly, the third type of reflex we have is your polysynaptic reflex. So a polysynaptic reflex has greater or more than two afferent and efferent neurons. So one example is your flexor withdrawal reflex. So I don't know if you've heard of this, but let me just give you a brief overview of what your flexor withdrawal reflex is. So basically what this is that for example, diba, when you're lying down and someone tickles your foot, what is your first instinct? Diba? It's to pull your entire lower extremity away from the stimulus, right? Or also if, for example, makibot ka, like when you're walking and you step on something you were not expecting to step on, diba, you immediately pull your entire leg away from that stimulus. Well, that is your flexor withdrawal reflex. It is a protective reflex wherein you withdraw from a stimulus so that you won't get injured or you decrease the possibility of getting injured. That is your flexor withdrawal. And in this case, for example, when you're lying down and someone tickles your foot, right, and you pull away, what you're contracting, the muscles you're contracting is not just one agonist muscle. So it's not just your quadriceps, it's not just your iliopsoas, it's not just your gastrocs, right? So you're contracting a lot of muscles at the same time, and a lot of the antagonist muscles of all of those muscles are also being inhibited at the same time. So you require now more than two motor neurons as well as more than two sensory neurons. So an example again of a polysynaptic reflexes is your flexor withdrawal. So most complex reflexes are actually polysynaptic, right? So there are a lot of other examples, but for your monosynaptic and bisynaptic, usually it's just your DTR and your reciprocal inhibition. Next, let's discuss how common DTRs are tested. First, we have our jaw jerk reflex, which is elicited by tapping the mandible, and the normal reaction would be for your mouth to close. So this is testing for integrity of cranial nerve number 5 or your trigeminal nerve. Next, you have your biceps tendon reflex. So you tap on your biceps tendon, and the resultant action would be elbow flexion, and this is testing for the level of C5 to C6. Next, you have your brachioradialis reflex. So you tap on your brachioradialis tendon or near its junction, and then the response elicited should be elbow flexion and a bit of forearm pronation. So this is testing for the C5 and
So this is
C6
assessing
integrity
for
of the
integrity
reflex
of the
arc.
C5 to C6. Your triceps reflex is assessed by tapping on your triceps tendon, and the normal reaction would be for elbow extension to occur. And you have here testing for C7 to C8 level. Next, you have your patellar tendon reflex. So this is the most famous one and the most usual that you see being tested. So the patellar tendon reflex, it happens when you stimulate or you tap on the patellar tendon, which is found just inferior to your patellar bone. And when you tap on that tendon, what happens or the normal reaction should be leg extension. So this is assessing for the levels of L3 to L4. In testing for your medial hamstrings reflex, so you tap on your semimembranosus tendon, and this is assessing for L5 to S1 level, and the action, the corresponding normal reaction should be knee flexion. For the lateral hamstring, should be elicited at the level of your biceps femoris tendon, so the same action would occur with your medial hamstrings, knee flexion, and this test for the level of S1 to S2. Next, you have your tibialis posterior reflex. So you tap on your tibialis posterior tendon near your medial malleolus, and the correct reaction or the normal reaction should be ankle plantar flexion with inversion, and this is testing for integrity of L4 to L5. And lastly, you have your Achilles tendon. So you tap or you stimulate your Achilles tendon, and the normal reaction should be plantar flexion, and this is assessing for S1 to S2. So usually when we're testing for deep tendon reflexes, more or less, this is just to confirm if the lesion is an upper motor neuron or a lower motor neuron, and to assess if these levels are intact. So usually, if we get the normal amount of reflex, you call that as normoreflexive, right? Or normoreflexia. If the reflex is heightened or there is an excessive response to your stimulus, you call that as your hyperreflexia. When the reflex is decreased, right? So you call that as your hyporeflexia. So usually upon assessing these deep tendon reflexes, which are again monosynaptic reflex, we get to determine if what is happening is indeed an upper motor neuron lesion or a lower motor neuron lesion. So we attribute upper motor neuron lesion to hyperreflexia. You get hyporeflexia, it is being attributed to your lower motor neuron lesion. So by definition, again, an upper motor neuron is anything above your anterior horn cell. Anything below the anterior horn cell up until the effector organ is considered a lower motor neuron. So for the lower motor neuron lesion, an example of this would be for your peripheral nerve injuries. So for example, you've injured some parts of your brachial plexus, so that would be considered a lower motor neuron lesion, and the resulting symptom would be a hyporeflexia, which is a decreased response to a stimulus for the DTR. Next, we have your superficial reflexes. So number one, you have your upper abdominal reflex. So what happens in this reflex is that you stimulate upper lateral portion of your umbilicus or your belly button. And the normal reaction should be your umbilicus should go upwards and lateral towards the side that is being stimulated. And this assesses for the integrity of levels T7 to T9. With your lower abdominal reflex, so you stimulate the lower lateral side of the umbilicus, and the normal response should be that the umbilicus would move to the side being stimulated. And this is assessing for the integrity of levels T11 to T12. Next, you have your cremasteric reflex. The stimulus is now stroking of the inner thigh, and this would cause elevation of your scrotum, specifically towards the side being stimulated, and it assesses for the levels of T12 to L1. Next, you have your plantar reflex, wherein you stimulate the plantar aspect of your foot, resulting in flexion of toes, and this assesses for your S1 to S2 integrity. Next, you have your gluteal reflex, would elicit contraction of your gluteal muscles. So that's L4 to L5, S1 to S3. And lastly, you got your anal superficial reflex, wherein stimulation of near your perianal area would result in contraction of your anal sphincter. And this is assessing for S2 to S4. So all of these reflexes we've talked about, they can help with determining which level of the CNS is affected. Now let's talk about your pathological reflexes. So these types of reflexes will only become positive if there is a sort of problem with your central nervous system. So you have your Babinskis, your Chadoks, Oppenheims, and your Gordons. And all four of them, although they have different stimuli, they have the same response, which is extension of the big toe and fanning of the other toes. So for your Babinski, the stimulus is stroking on the lateral sole of the foot. For Chadoks, that's stroking inferior to the lateral malleolus. For Oppenheims, that's stroking on the anteromedial aspect of the tibia. And for Gordons, that's squeezing of the calf muscle. All four of these, again, have the same response if they are positive, which is big toe extension and fanning of the other toes. So indication of all these four reflexes could possibly be a pyramidal lesion. So next you have your Piotrowski's. So Piotrowski's is stimulated by percussion of your tibialis anterior muscle, and the corresponding response, if it is positive, is ankle dorsiflexion and supination. So this would mean that there is a pathology somewhere with your central nervous system. Next, you have your Brudzinski's reflex. The stimulus is passive flexion of one lower X, and the response would be the same movement in your left lower extremity. So normally, no, when you flex one lower X, the other one should be able to do a separate thing. But in the case of Brudzinski, so passive flexion of one lower X, the same movement occurs with the other leg as well. So usually this is determinant of the pathology called meningitis, which is an inflammation of the meninges of your brain and spinal cord. Next, you have your Hoffman's. So with the Hoffman's, the stimulus is flicking of the distal phalanx, either of your index, middle, or ring finger. And the response, if this is positive, would be that they reflexively do flexion. So if you flick the index, for example, there would be automatically flexion of the index finger. The same as goes with the middle and the ring finger. And usually in a person without pathology, when you flick either of those digits, that digit can remain in a neutral position without the rebound flexion. And your Hoffman's can be a determinant that a person has a tetany or natatanos siya, or a person has a pyramidal tract lesion. Next, you have your Rossolimos. So Rossolimos is elicited by tapping the plantar aspect of the toes, and the response is toe plantar flexion. So again, this does not happen in a person without pathology. So when Rossolimos is positive, usually determinant of a pyramidal tract lesion. Next, you have your Schaefer's. So Schaefer's is stimulated when you pinch the middle one-third of your Achilles tendon, and the response usually would be flexion of the foot and toes. So this reflex, your Schaefer's reflex, is positive usually with hemiplegic patients. So to clarify, your pathological reflexes, your Babinski, Chadok's, Oppenheim's, Gordon's, Piotrowski's, Brudzinski's, Hoffman's, Rossolimos, and Schaefer's, they are not again positive in normal individuals. They only come out when there are certain pathologies. And unlike deep tendon reflexes, wherein we have normal reflexia, hyperreflexia, with your pathological reflex, you only get positive or negative, right? So if it's negative, that would be determinant, or that could be a factor in which you can rule out certain pathologies, right? And if it's positive, you can rule in certain pathologies. Now let's talk about muscular signs and symptoms related to nervous system lesions. So first you have your hypotonia. This is a decrease in muscle tone. So usually you see hypotonia in patients with lower motor neuron lesions. With hypertonia, it's opposite. So you have an increase in muscle tone. So that could be spasticity or what you call rigidity. And what results in hypertonia usually comes from your upper motor neuron lesion. So any damage to your tracts or to your brain. So hypotonia is for a lower motor neuron lesion in general. Hypertonia is from an upper motor neuron lesion in general. Next, you have your tremors. So, what are tremors? So, these are rhythmic, involuntary co-contraction of your agonistic and antagonistic muscles. So, in a person with no pathology, usually a smooth movement can be carried out with varying degrees of contraction of the agonist and antagonist muscles. But with tremors, usually there is co-contraction with your agonist and antagonist muscle at the same time, causing you to have these shaky movements, which are known as tremors. There are different types of tremors. You have your resting tremor, which is a type of tremor that is present at rest, and usually you see these in patients with Parkinson's disease. You also have your intention tremor. So with intention tremor, the difference is that now you only get tremors when you're near your target object. So let's say you're trying to reach for a glass of water. When your hand nears that glass of water, your tremor intensifies, and this is what we consider to be as your intentional tremor. So intention tremor is a specific type of tremor seen with diseases of the cerebellum. Again, you have two major types of tremors. Your resting tremor, present at rest and gets decreased as you do the movement, which is present in Parkinson's disease and is associated with basal ganglia diseases. You also have your intention tremor, which is a type of tremor not present at rest but increases as you get near your target object or as you get near the end of your movement. So that's why it's called intention tremor, because it gets stronger the nearer you get to do your intention action or intended action. So this has associations either with your basal ganglia or your cerebellum. Next, you have spasms. So spasms are sudden contractions of large group of muscles. So let's put that large muscle groups. So these are involuntary and usually happens with damage to your descending tracts. Next, you have your athetosis and your chorea, as well as your hemibalismus. So all these three are types of movement disorders in which the affectation usually is found within your basal ganglia. So first, you have your athetosis. So these are slow, continuous, dysrhythmic movements of the body that disappears during sleep. And with athetosis, you get a lesion, usually with your corpus striatum. With your chorea, so your chorea is also another type of movement disorder. So this is opposite to your Parkinson's disease, because with Parkinson's disease, it's a type of hypokinetic movement disorder, which means that a person who has Parkinson's disease would usually have slower amplitude of movements, slow execution of movements, wherein your athetosis, chorea, and hemibalismus are hyperkinetic movements. So they usually present with fast movements. So your chorea is presented with purposeless, fast movements that occur with damage as well to your corpus striatum. Next, you have your hemibalismus. So these are movements present with only one side of the body, and these are rare. So usually just one side and usually proximal muscles. So there is affectation with your subthalamic nucleus. Next, you have your dystonia. So your dystonia, these are sustained muscle contractions. That's the posture that arises from those varying contractions. So this happens with damage to your lentiform nucleus. Next, you have your myoclonus. So these are sudden jerking of specific limbs or muscles, usually associated with cerebellar lesions or lesions of your reticular formation. So that's it for our discussion about intersegmental tracts. So thank you for listening. God bless.